Mhm. Dr. Toomey also states that clinical anatomy of the lumbar spine and sacrum provides the reader with the underlying knowledge essential for understanding pathology and therefore informed and logical treatment, kind of like what you're mentioning. Haven't we learned, though, that pathoanatomical approach is faulty in determining a precise diagnosis and short-sighted in determining the most effective treatment? And don't we need to move on from this?
Well, what you've incorporated into your question is actually akin to a religious pronouncement.
Okay.
I know that it is socially popular to declare it hasn't served us at all, and therefore it doesn't apply. Or the instruction being, forget it, don't go down that path, and you're heretics if you do, or something like the Antichrist.
Yeah.
And I'm choosing my words premeditatedly with this flavor of religion, because the opposing view that I'll state briefly is, well, how sound is diagnosis by imagination? That I know what the cause is because I said so. And these are the properties of eminence-based medicine. Like, I wrote a book on surgery, and therefore I'm telling you what's wrong with these people. Or I wrote a book on manual diagnosis, and I'm telling you what's wrong with these people. And too many groups behave like guilds, and that is that they train their people with consensual intercongruity, which means that if we see the same thing, like tenderness or stiffness, then we are taught to apply a particular diagnostic label to that. It occurs even in medicine. Reflect on what really are the diagnostic criteria for osteoarthritis of the knee. And if you look not too deeply, it's painful knee in old person. And we are taught to say, well, you've got osteoarthritis. But there are no objective criteria other than old person says my knee hurts. So we were taught to call it osteoarthritis. The science behind diagnosis asks for more information, empirical data. And then I don't want to divert too far into issues of taxonomy, that you have to set up operational criteria, that what distinguishes this condition that you want to name from others that resemble it. Yeah. And there are rules to follow in order to be able to do that. But overall, it requires empirical data by which I can tell the difference between an ad hoc, self-serving assertion from something that has been derived objectively and calmly from empirical data. But there is now a historical dimension. Research into lumbar spine lags by 400 years behind research into cardiology. Harvey started looking at the heart in the 1600s and established then a process of cardiac physiology, exercise physiology, and then ultimately cardiology. Lumbar spine was ignored until the middle 1970s. Now, for anybody to make a diagnosis, you need the appropriate tools. Cardiologists developed that. But if we were just left with a stethoscope, we would not be making diagnoses of anterior coronary artery occlusion. We would not be making diagnoses of sinoatrial node block. So diagnosis becomes possible, in a pathoanatomical sense, only when you have tools that are appropriate to make that diagnosis. If we didn't have chest x-rays, if we didn't have bacteriology and pathology labs to analyze sputum, we'd still be saying that people who have respiratory difficulties have galloping consumption. We would not be using the word tuberculosis. Mm-hmm. So you need the appropriate tools. Yeah. And those tools have only started to emerge in recent decades. Plain x-rays were good for major problems like an obvious tumor or massive fractures of the spine, but they couldn't tell you anything about soft tissues. We had progress when MRI was developed, and then we get further progress when fluoroscopically guided diagnostic blocks became available. And in the realm of instability, the old literature dating from 60s, 70s, last century, and up until recent times, instability was a diagnosis by assertion because there were very few objective criteria available because the tools for the detection were not available. But if you now have access to cine radiography that can print multiple exposures of a moving spine during the range from flexion to extension or vice versa, you can start finding the correlates of instability. But if you're just looking at a plain film, you can't see them. If you are just palpating the patient, you can't see them. So pathoanatomic diagnosis relies on the tools for making that diagnosis becoming available. And it is only in the last half of my professional lifetime that those tools started to emerge. But even those tools are subject to the rules of biostatistics. What's the reliability? What's the validity? So, for example, if you want to find instability and looking at flexion extension views at 200 millisecond intervals during the movement, you first better tell me that the two observers that are analyzing the same films actually agree and don't have an error of 3 millimeters or 7 degrees when they detect an abnormality. So the rules apply to everybody, but the tools have to be calibrated and then applied. And I'm encouraged that the more that the tools have become available and the more that people start using the tools, we have moments of voila, there it is. I've got it. I've seen something. Mm-hmm. And for example, you can't see paradoxical motion in the lumbar spine unless you have detailed x-rays with precision calculations, drawing lines and measuring it with protractors, or using a computer built into your x-ray machine to do the calculations for you. And you say, oh, shit, I've just seen something that nobody's seen before, and which was not apparent to people who just palpate patients or just listen to their history.
Yeah.
Over to you.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.